Welcome back to the deep dive. We're here to give you that crucial information fast.
That's right.
And today, we're tackling small cell lung cancer, SCLC.
A really important one.
Definitely. We've taken a whole stack of revision notes, the kind you need for exams like the MSRA, and boiled them down.
Yep, the absolute essentials. We want to give you a solid handle on this condition because it is, well, pretty aggressive.
Exactly. So let's dive right in. What is small cell lung cancer, fundamentally?
Okay, so SCLC. It starts in the lining of the bronchi. The air passages in the lungs.
Right.
The name gives clues. Small refers to the cell size under the microscope. Tiny cells. But the key behavior descriptors are fast-growing and aggressive.
Aggressive meaning it spreads quickly.
Precisely. Think rapid spread, metastasis, that's its signature move, really. So one of the two main types of lung cancer, the other being non-small cell or NSCLC.
And SCLC is the less common one.
It is. Makes up about, say, 15% of all lung cancers. And it has this really strong link with smoking, heavy smoking especially. Often think central smoker's cancer because it typically arises in the central airways.
Central, okay.
Highly malignant, frequently involves the mediastinum, that space between the lungs with all the important stuff.
Right.
And unfortunately, it tends to have early extrathoracic metastases spreading outside the chest and can also cause these things called paraneoplastic syndromes.
Ah, yes, those systemic symptoms that aren't directly from the tumor mass itself.
Exactly. And because it moves so fast, diagnosis often happens when it's already quite advanced. That's why surgery isn't commonly an option.
Makes sense. So let's talk causes, the etiology. What's the main driver here?
Number one, overwhelmingly, is tobacco smoking, particularly heavy, long-term smoking history.
No surprise there. Anything else?
Yeah, definitely. Secondhand smoke is also a risk factor, and exposures like asbestos and radon gas.
Right. So smoking is the big one, but other environmental factors play a role too.
Absolutely. Those are the key risk factors to keep in mind. Cigarette smoking, first and foremost, then passive smoking, certain occupational exposures, and sometimes family history.
Okay. Now, pathophysiology. What's actually happening at the cellular level that makes it so aggressive?
It really comes down to that abnormal, uncontrolled growth of those small cells in the bronchi.
Right.
The defining features are just incredibly rapid growth. That early metastasis we talked about just seeds itself elsewhere very quickly, and invasion into nearby tissues and organs. It doesn't tend to stay put.
So if someone comes in with symptoms, maybe a persistent cough, shortness of breath,
Right.
what else are we thinking about? What's on the differential diagnosis list?
Good question. The main thing you need to differentiate it from is the other major lung cancer type, non-small cell lung cancer.
Which includes adenocarcinoma and squamous cell.
Exactly, those subtypes. But you also need to consider infections like pneumonia or even tuberculosis. They can sometimes present with overlapping symptoms, cough, breathlessness.
True. Okay.
Yeah.
And how common is SCLC? What about the epidemiology?
Well, as we said, in the UK, it's around 15% of all lung cancers. That figure holds pretty steady globally, too.
And who gets it typically?
It tends to be diagnosed more in older individuals,
Yeah.
particularly people aged 65 and over.
Okay. Let's talk clinical presentation then. What are the red flags, the typical signs and symptoms we need to recognize?
The common ones are things like a persistent cough, and the key here is duration, often lasting more than 6 weeks.
6 weeks, okay.
And shortness of breath, maybe some chest pain, coughing up blood, that's haemoptysis.
Right.
Also fatigue, losing weight without trying, and getting recurrent chest infections.
So a constellation of respiratory and systemic symptoms.
Exactly. And it mainly affects people over 40, strongly linked to that smoking history. So you really need to consider SCLC in any smoker over 40 who develops new respiratory symptoms that hang around for more than 6 weeks.
Got it. Crucial point.
Yeah. And while early signs can be subtle, a good chunk, maybe 40%, already have symptoms coming from inside the chest when they're diagnosed.
Like the cough you mentioned.
Yes, cough, but also difficulty swallowing, which is dysphagia, haemoptysis again, difficulty breathing or dyspnea, weight loss, chest pain, fatigue, night sweats, fever, maybe a hoarse voice, even finger clubbing sometimes.
Wow, quite a list.
And remember, those extrathoracic metastases are common.
Where does it typically spread?
Common sites are bones, the liver, adrenal glands, lymph nodes far from the chest, the brain, and the spinal cord.
And those cause their own symptoms.
They do. Things like general fatigue, weight loss, bone pain or tenderness, maybe confusion if it's in the brain. In the enlarged liver, swollen glands you can feel, headaches, nausea, vomiting. It depends where it's gone.
And the paraneoplastic syndromes, how common are they?
They occur in about 10% of patients.
Huh?
These are those systemic effects, often hormonal, not directly caused by the tumor's physical presence. Things like SIADH causing low sodium or Cushing's syndrome.
Right. So if SCLC is suspected, what's the workup? What investigations are key?
Okay, so investigations. You start with some general blood tests, things like LDH, lactic acid dehydrogenase, that might be elevated, and check electrolytes, hyponatraemia, low sodium is quite characteristic sometimes.
Good markers to remember, LDH and sodium.
Definitely. And liver function tests, LFTs, are important
Like
too.
an imaging.
Imaging, yes. Usually starts with a chest x-ray, a CXR. Then typically a contrast-enhanced CT scan of the chest for more detail.
CT provides a better picture of the extent.
Much better. And often a PT-CT scan is done. That looks for metabolic activity, so it's great for seeing how widespread the cancer is, picking
Yeah.
up active spots.
Okay. And confirming the diagnosis.
You need tissue. So a biopsy, this is often done via bronchoscopy, where they put a camera down into the airways,
Right.
or increasingly using EBS, TBNA, endobronchial, ultrasound-guided transbronchial needle aspiration. It's a way to sample lymph nodes in the chest very effectively.
That sounds quite specific.
It is very useful. If those methods don't work, occasionally a surgical biopsy is needed, but that's less common.
And staging. Finding out exactly how far it spread.
Staging procedures build on that.
Hmm.
The PET scan helps a lot. Sometimes specific bone scans are needed, maybe an ultrasound of the neck to check lymph nodes there.
And evaluating specific areas for spread.
Yes. So contrast-enhanced CT or MRI scans of the brain are standard because brain mets are common. Bone scanning, if not already clear from PT. Maybe liver ultrasound and potentially a biopsy if there are suspicious lesions there.
So it sounds like staging is really about figuring out if it's contained or spread out.
Yeah.
How is it formally staged?
That's exactly it. For SCLC, the main staging system used clinically is quite simple. Limited stage versus extensive stage.
Okay, what defines limited stage?
Limited stage essentially means the cancer is confined to one side of the chest, one hemothorax.
Just one side.
Yes. It can include lymph nodes near the lung root on the same side, the hilar nodes. It can also include lymph nodes between the lungs, the mediastinal ones, and those above the collarbone, the supraclavicular ones, potentially on both sides. But crucially, all potentially encompassable within a single radiation field.
Ah, okay. So treatable with radiation to one area.
That's the idea behind the definition, yes. It might also include a pleural effusion, fluid around the lung, but only on the same side.
And extensive stage.
Extensive stage is basically anything beyond that. So if the cancer has spread to the other lung,
It's contralateral lung.
yes, or if there's distant metastatic involvement anywhere else in the body, liver, bone, brain, adrenals, distant lymph nodes, that's extensive disease.
I see. Is the standard TNM staging used at all?
It exists. The American Joint Committee on Cancer,
Yeah.
AJCC, TNM system, T for tumor size extent, N for nodes, M for metastasis.
Right.
But it's rarely applied in routine clinical practice for SCLC. The limited versus extensive system is just more practical for guiding treatment because the disease is often systemic even when it looks limited.
That makes sense given how quickly it spreads. So how do we manage SCLC? What are the treatment approaches?
The mainstays are chemotherapy and radiation therapy. Surgery, as we mentioned, is very rare, only for maybe the absolute earliest stage, which is uncommon to find.
Chemotherapy and radiation are key then.
Definitely. And newer therapies like targeted therapy and immunotherapy are starting to find a role in specific cases, often in combination or later lines.
Okay. Can we break down the prescribing management based on stage?
Sure. For limited stage disease, the standard is concurrent chemoradiotherapy. So chemotherapy given at the same time as radiation therapy to the chest.
Okay.
And very importantly, often followed by prophylactic cranial irradiation PCI. That's preventative radiation to the brain.
Why preventative radiation to the brain?
Because the brain is a very common site for SCLC to spread to, and chemo doesn't cross the blood-brain barrier very well. PCI significantly reduces the risk of brain mets developing later.
Got it. Makes sense. And for extensive disease?
For extensive disease, the backbone is platinum-based chemotherapy, usually something like cisplatin or carboplatin combined with etoposide. Thoracic irradiation might be considered later, perhaps for symptom control in the chest, but chemo is the primary systemic treatment. Immunotherapy is also now often added to initial chemo for extensive stage.
And if the cancer comes back, relapse.
If it relapses, then it's on a second-line chemotherapy. Options there include drugs like topotecan or combination regimens like CAV, cyclophosphamide, doxorubicin, vincristine.
Right. And pain management.
Crucial. Often requires strong opiates like morphine, to manage pain effectively, especially with bone metastases.
What about non-prescribing management?
Absolutely vital. Top of the list always is strongly advising and supporting patients to stop smoking. Even after diagnosis, it can improve treatment tolerance and outcomes.
Critical advice.
Definitely. As we said, surgery is rare. Supportive measures depend entirely on the stage and where the metastases are managing nausea, fatigue, nutritional support, psychological support. Radiotherapy can also be used palliatively, for instance, to treat painful bone mets or brain mets causing symptoms.
Any specific complications to manage?
Superior vena cava obstruction (SVCO) can occur if the tumor presses on the large vein draining the head and arms. That's an emergency. It might require radiotherapy or stent insertion.
Okay, a lot to consider in management. Finally, let's talk prognosis. What's the outlook generally?
Yeah, unfortunately, because it's often diagnosed late and is so aggressive, the overall prognosis for SCLC is generally poor compared to NSCLC.
Even with treatment?
While initial treatment, especially for limited stage, can lead to a good response, even remission, relapse is common. The 5-year survival rate is significantly lower than for many other cancers.
Do we have specific numbers?
Looking at UK data, say from around 2013-2017, about 40% might live for 1 year or more after diagnosis. But 5 years or more, that drops to around 16%. And predicted 10 years is under 10%.
Wow, those are sobering statistics.
They are. There are some influencing factors. Females tend to have slightly better survival rates than males at 1, 5, and 10 years. Younger patients, say under 40, also tend to do a bit better, though it's rarer in that age group. But survival hasn't improved dramatically over the past few decades, unfortunately.
Does stage at diagnosis make a big difference?
Huge difference. If rarely it's caught at a very early stage, survival is much better. 1 year survival might be closer to 90% and 5 year around 50–60%. It really underscores the importance of trying to catch it earlier, though that's challenging.
And reinforces the link to smoking.
Massively. Tobacco use is linked to over 80% of all lung cancer deaths. Primary prevention, not smoking or quitting smoking, is by far the most effective way to reduce the burden of this disease.
Are there screening programs?
Not a national one in the UK currently. The US does recommend low-dose CT screening, LDCT, for high-risk individuals like long-term heavy smokers, and studies show it can reduce mortality by about 20%. But SCLC grows so fast, screening is perhaps less effective for it than for NSCLC.
Right. A very challenging disease overall.
It really is. Ongoing research is looking for better therapies, better ways to overcome resistance, and improve those outcomes.
So summing up the absolute key points for everyone listening, especially if you're prepping for exams like the MSRA, SCLC is aggressive, fast-growing, strongly linked to smoking.
Think central location, early metastasis, paraneoplastic syndromes.
Staging is mainly limited versus extensive guiding treatment, which relies heavily on chemo and radiation. PCI for limited stage is key.
And prognosis is generally poor, making smoking cessation and prevention paramount. Early diagnosis dramatically improves outlook, but it's often diagnosed late.
Excellent summary. Keep those high-yield facts front of mind.
Absolutely. And if you need more resources, practice questions, and in-depth guides to nail the MSRA or other medical exams, definitely check out passthemsra.com.
And don't forget the free resources available at freemsra.com too. Thanks for joining us on The Deep Dive.